and welcome. Thank you for joining me on another episode of Carroll PMC's video interview series. I'm excited to have you with me today as we discuss another's journey through medicine. And today, I have a great guest for you all, Dr. Doug Kuntzweiler. He is a Vietnam veteran who has worked as a public health service employee, a provider on multiple Indian reservations, the only family medicine doc in a small rural Montana town, and most recently, as an emergency medicine doc at St. Peter's Health. He is recently retired and is also married to Dr. Erin Kuntzweiler, who was a nursing professor here at Carroll for a number of years and is currently a provider at Sage Medical Clinic in Helena. So, let's jump right in and say hello to Dr. Kuntzweiler. Dr. Kuntzweiler, welcome to Carroll PMC's video interview series.
Thank you. Happy to be here.
When did you realize you wanted to be a physician?
I came to it late. I was not somebody who knew they always wanted to be a doctor. When I graduated from high school, the Vietnam War was going on, and I was going to be drafted. I didn't want to be crawling through the jungle with a rifle, so I enlisted in the Air Force, and that was a 4-year commitment at that time. I went in 1970. They wound up training me as a Chinese linguist, and I spent 2.5 years in Southeast Asia, some of it riding around in an airplane, some of it on the ground, basically listening to Chinese military communications and trying to keep myself and my fellow soldiers safe. So when I got out of the Air Force, I had the GI Bill. I didn't really know what I wanted to do, but I had always loved biology. I'd always loved the outdoors and animals. And so I went to Iowa State because I grew up in Iowa. I went to Iowa State and I majored in ecology, which was a relatively new field at that time. And the ecology program at Iowa State was a pre-professional program. You had to take organic chemistry and biochemistry and genetics and comparative anatomy and all that. The same courses as all the other pre-professionals, pre-med, pre-dental, pre-veterinary. Iowa State had a good veterinary school at that time. And so I was in the mix with all those students, and I was doing well academically. And I realized not until the summer between my junior year and my senior year, I realized that at that time, this was 1977, there were no jobs in ecology, pretty much. It was, an academic sort of prep degree, but there really, unless somebody died somewhere, there was nowhere you were going to go to get a job. So I had to think about, well, what am I going to do next? Do I want to, work for a PhD and hope to a professor somewhere dies and I can take their place? And when I compared myself to my fellow pre-med and pre-dental students, I thought, well, I could do this. And then I sort of started thinking about, what do I really want to do with my life? And my experience during the Vietnam War, I'd seen a lot of suffering in the world, and I thought, well, it'd be good to get into medicine and do something that would actually help relieve suffering. And so I came to it very late. In fact, I made the deadline to sign up for the MCAT that summer by about a week. I made my decision to apply, and I had 1 week to sign up for the MCAT. And so then I went to the University of Iowa Medical School. And that was I started in 1978, July of 1978, I think. So I came to it late. I didn't always know that I wanted to be a physician. It was sort of a sit down and think about, what do you want to do with the rest of your life moment. And that's how I came to it.
Right, and that's interesting because a lot of pre-meds, at least it's a general trend for a lot of pre-meds to come into medicine because of some usually horrible experience. Usually it's a childhood traumatic experience, the death of a loved one, a really bad accident. But sounds like you came in from just a series of different experiences that built you up. And I'm curious about that, specifically in regards to the Vietnam War. Were there any specific experiences within that? I know you touched on, human nature and maybe wanting to do something better after seeing so much violence. Was
Yeah.
there any particular experience
No, and it wasn't so much the violence as it was just seeing the poverty and the way people lived. Like I spent a year in a small town in northeast Thailand, very rural, and you know I grew up in a sort of lower middle class family in Iowa, but this was something like I had never seen before. And I spent a little time in the Philippines, and you know saw the slums around Manila, and it was more just seeing how miserable some people's lives were. I mean, the war, of course, yeah, there was a lot of violence. You sort of expect that in a war, though, you know, and that's not to sanction it, but that was sort of a given. But to see how horrible some people's lives were really made a big impression on me. So.
Were there any experiences in your undergraduate institution, like maybe shadowing or talking to some mentors that then pushed you even more towards medicine?
No, no, not really. But what I remembered, I was kind of a sickly child. I had rheumatic fever and I had all the usual childhood diseases back then. There were no immunizations. So I had measles, I had mumps, I had rubella, I had chickenpox, and then I got rheumatic fever. So I was kind of a sickly kid. I was hospitalized once when I was in junior high. I had a kidney infection, which is sort of a weird thing to get. But I had very good doctors, small town family doctors, and I think they had an influence really on me too. But not really any experience as an undergraduate, except seeing that I was doing as well as the pre-med and the pre-vet students were, and so that encouraged me that I could do it.
Right. Usually that that hoop, getting over that obstacle of self-doubt or feeling like an imposter,
Yeah,
as people usually call it. That's the first
yeah,
major step.
yeah,
Toward
yeah, really.
Yeah.
But the thing I learned was that it's not how bright you are, it's how hard you can work, really. And I was an older student. As I'd had the war experience, so I was 4 years older than all the other freshmen when I started, and so I didn't have that partying and first time away from the family home and all that sort of stuff to go through. I had already gotten through all of that, and I think that helped me a lot because I was able to really focus on my studies, and that helped me to succeed. It wasn't that I was any smarter than anybody else. I just had some motivation to work hard, and I think that's true of medicine too. It's true of medical school. I mean, I went to medical school with a lot of really brilliant people, but that didn't always translate into people skills. It didn't always translate into them being great practitioners. It really, the people who did the best were the people who could just work hard, put in the time.
Right. Discipline equals freedom. That is great. And so you alluded to an advantage by being a non-traditional student, which
Yeah.
more and more applicants to medical school are becoming now.
Yeah.
Was there any disadvantages for being a non-traditional student as far
Well,
as?
they weren't very common. When I think of my my medical school, there were only about 4 or 5 of us out of a class of, I think we were around 100. There were only 4 or 5 of us who were non-traditional, who had done other things. So there was a little bit of, if anything, there was maybe a little bit of isolation, because we're at a different phase in our lives. I was married and already had a child and another one on the way, and so maybe couldn't relate quite as well to my classmates. But that was a pretty minor thing, I would say. I can't really say that there were a lot of disadvantages. No, not really.
Okay. So you decided to pursue an avenue for paying for medical school through the public health service, in which you agreed to serve in a health manpower shortage area. Can you describe what motivated you to pursue this path of financing medical school, as well as just in general what it was like?
Yeah, poverty. No, I was fortunate. When I got out of the Air Force, I had the GI Bill, and that paid for all of my undergraduate, and that was the old GI Bill. now it's a sort of a matching program. You save money while you're in the military, and the military matches it. But back then, they would pay your full tuition for any recognized schooling, and then they bought your books. You just turned in a receipt and they paid you for your books, and then they gave you a monthly stipend to live on. And it wasn't much, but that got me through undergraduate without having to take out any loans at all. And I worked in the summers and stuff like that. But so when I got to medical school, the tuition and everything was pretty daunting. Nothing like it is now, but for the time it was pretty expensive. And I think Iowa was a relatively cheap school, especially for an Iowa resident, which I was. But it was still, I was going to have to borrow a lot of money to get through, and I really didn't want to do that. And on the other hand, my motivation, what I really aspired to, was to be a small town family doctor. That really is what I wanted to do. And the public health service fit that pretty well. So the program back then was you signed up and they paid your tuition, and they gave you some money for textbooks, although they didn't buy your textbooks for you. They gave you an allowance each semester for it. And there was no stipend for living on or anything like that, but they paid your tuition, and that was a big deal. And in return, you agreed to serve in a health manpower shortage area for the number of years that you had support from them. So I signed up for the program right away as a freshman, so I had 4 years of obligation. But I didn't see it that way because it was what I wanted to do anyway, and I just saw it as a way to help me financially get through medical school. Now, I still had to borrow some money to live on, but nothing like what I would have had to if I hadn't done that. And when I talked to some of my younger partners that joined me in the ER in these last 5, 6, 7, 8 years, I mean, they have really pretty staggering debt loads that they are still paying off. So it worked out well for me because it's what I wanted to do anyway.
Right. And I know there's multiple different forms of manpower shortage areas and different forms of the scholarship, which I think there's one that goes through, at least one that I and a lot of pre-meds have looked at. It's the National Health Service Corp, where it's like a loan repayment program too. So I know this comes in various different flavors as well. What was it like, specifically touching more on the poverty side of things? What were some of the most immense and most noticeable problems associated with people who are in poverty that you serviced, as far as medical conditions and also problems and disparities in access to healthcare?
Yeah, well, so I went through a matching program. I knew at that time I had been doing some backpacking in the Rocky Mountains, and I knew I wanted to move out of Iowa, flatland, and get into the mountains. And so when I went to look at areas where I could serve, I looked at Rocky Mountains and Northern Rockies. And I had spent a summer when I was in medical school working at Rocky Boy Reservation. And so I knew Montana a little bit. So I selected Boulder, Montana, because it was in a nice location. It was a cool little town, I thought. It was relatively close to Helena, and I was going to be able to use St. Peter's as my hospital base. Even though I had about a half-hour commute, but that worked out pretty well. And so I moved my family to Boulder. We lived in Boulder. I was the only doctor in Boulder. And it was health manpower shortage. Most people were employed, but a lot of people were in kind of low-paying jobs, especially like the people that did the direct care at the Montana Developmental Center. They were basically like nurses' aides. Most of them had maybe a junior high or a high school education. They didn't have any further education, and they were low paying jobs and they were difficult jobs. I saw a lot of substance abuse. I saw a lot of bad nutrition, just general poor health habits. And then there were people that lived in the outlying area, mostly older folks who kind of lived up in the mountains, and some of them had been interesting people. Some had been prospectors, some had been ranch hands, stuff like that. But they didn't come even into the town of Boulder very often. And if they were sick, they waited until they were half dead before they came in. So I saw a lot of pathology, more than I would have expected in America. But it's because Boulder was a relatively impoverished area, and and when you get into areas that are either very rural or even frontier, which is that sort of describes Montana, you're going to see a lot of pathology that hasn't, people just don't go to a doctor because it's difficult for them. It's expensive. It's difficult to travel. Doctors are in the rural areas are pretty few and far between, and so people just don't go until they're really sick. So I saw a lot of crazy stuff.
Definitely. Now, let's shift from the patient to the provider now, because as an EMT with Eagle, I oftentimes respond in place of Boulder Ambulance because it's a volunteer service, and
Right.
oftentimes there's lack of staffing because there's not an efficient amount of a large enough amount of volunteers
Yeah.
to
Yeah.
staff them. So, as far as your support and resources went as you were working in Boulder,
Yeah.
can you elaborate on just how that was? It sounds like you were strapped. I mean, by virtue of a health manpower shortage area, you were probably strapped for resources. Can you
Yeah.
elaborate on that? Is that a correct assumption?
Yeah, it is. One thing about rural areas, there's been a history in Montana of having really excellent volunteer EMT services, though. That was true then anyway. I think maybe it has deteriorated some now, I would expect, but back then, and I got to Boulder in 1985. From 85 to 91, I was the doctor in town, and Boulder had a really good volunteer ambulance service at that time. Uh, and there were several EMTs in Boulder who had done a lot of teaching on a national level. So Boulder was kind of a hotbed of EMTs, but even at that, they struggled to get enough people to keep the roster full because it was volunteer. It interfered with their daily lives. I mean, all these people had jobs and they had families and they had other obligations. So it was hard to get people. I did a lot of teaching there. I did a lot of interaction with the EMTs because I was pretty much by myself otherwise. And when you're in a remote area like that, you are essentially the emergency room. So I had this little clinic that I worked out of, and I took one room and made that a resuscitation room. Uh, and so I had the ability to intubate people. I had the ability to start IVs, to do advanced cardiac resuscitations. Um, I could resuscitate trauma victims there. And I took these volunteer EMTs who were all basics at the time. In fact, when I started, there were no intermediate services in all of Montana. I helped do the first testing and training to advance from basic to intermediate and then to paramedic. So I took these basic EMTs and I would do evening sessions with them and I would teach them how they could assist me. Like if I were going to intubate somebody, how they could assist me. They'd get the tube ready for me and they could, spike an IV bag and get it hung up and ready for me to start the IV. And I had them trained to do as much as they could within, still being a basic EMT. So we worked hard at that, and that was pretty rewarding. I did a lot of teaching, and I liked that, and it was good for me because one thing I found when you teach something, you have to go back and relearn it yourself and make sure you really know what the hell you're talking about. And so I've always tried to do a lot of teaching, even when I was working in the ER. I still worked with EMT groups and nurses, and then later on, like physician assistants and stuff like that, because I really found that teaching was something that I enjoyed and something that forced me to make myself better. So, but the EMT services back then, those people worked hard. They didn't get paid for it. It took away from their regular jobs and families, but they did it because they really wanted to. First of all, they're interested in it, and they really wanted to help their fellow citizens. So it was pretty rewarding, I have to say.
Yeah, well, money sure as hell won't bring you to EMS. That's for sure. 'Cause you could probably make more
We
money at
found that out.
McDonald's. Yeah, but it's rewarding. I've loved doing it for the year and a half that I've done it so far, and I always like to mention um, Boulder Volunteer Ambulance on this video interview series because I encourage pre-meds currently to check it out if you have your EMT
Yeah,
license because they
yeah,
are strapped. I've spoke to Michelle St. George about it a lot. And
yeah,
yeah, responding from dinners, sit down for a dinner, pager goes
yeah,
off, gotta run.
yeah,
It's hard. But
yeah.
I'd like to also elaborate on something else you did. Maybe it was prior to or maybe during while you were in Boulder. And you mentioned it earlier, working on the Rocky Boys and Fort Peck reservations.
Yeah.
Just general question, how was that?
It was interesting. So when I was in medical school, after my junior year, so your junior year, you have your introduction to all of your clinical stuff. You're working in the hospital. You're actually doing some hands-on, medical kind of stuff. So you're not by any means ready to take care of anybody by yourself, but you've got some a little bit of practical experience. So I saw this advertisement. We had the third year. After your third year, that summer was free. There wasn't anything in particular you had to do. And I saw an advertisement in a journal uh, working for the Indian Health Service on a reservation as a third year medical student. And so I thought, well, that sounds great. And as I said, I'd been backpacking out in kind of northern Wyoming area, the Bighorn Mountains and stuff. And I fell in love with the mountains. And so I saw this ad and I looked at where the reservations were, and Rocky Boy it looked like was in the Northern Rockies. So I applied and got accepted. And so I took my family out there and we lived on the reservation. Rocky Boy is a pretty small reservation, but they had a house for us. And there was one doctor there, and it was Pat Walton, who became a plastic surgeon who worked in Helena, but he had just finished his internship year at the Mayo Clinic. So he knew a little bit more than I did, but not a whole lot. And so I worked with him all summer, and we worked in the clinic, and he and I alternated call at night. It was scary because I didn't really know enough to, be taking call, but he backed me up, of course, all the time. And but it was good for me because, again, it forced me to learn, and it forced me to get outside of my comfort zone and take some responsibility. And it was a great summer. The reservation itself, Rocky Boy, is fairly small, and in the summer, a lot of people aren't on the reservation. They go and do seasonal field work all across the Northwest. But like every reservation, there was poverty, there was substance abuse, there was a lot of violence, a lot of automobile wrecks, stuff like that. The people, when I first got there, not terribly trusting of white folks, but as time went on and as I got to know them and they got to know me, they actually were fine. They were just like people everywhere, and they had a good attitude towards life. They were fun to take care of. They were, especially the older folks, were funny, and I enjoyed it. I don't know if I'd wanted to live there the rest of my life, but I enjoyed that summer that I did. So then when I left the public health service, left Boulder, I wasn't really sure what I wanted to do. I was kind of looking around at various options. And from the time my practice ended in Boulder, I had a couple of months that were free. And so I signed up to do respite work for the Indian Health Service. So doing that, I went to Poplar, the Fort Peck Reservation. I went there a couple of times. I went to, I did a week at Malta as the town doc in Malta. That was pretty interesting. Malta's pretty remote. Poplar's pretty remote. And my experience there was about the same. Very remote, lots of poverty, lots of violence, lots of substance abuse, but underneath all of that, nice people and helpful people. So I enjoyed my time with the Indian Health Service on the reservations.
Right, yeah, what a great way to enrich your medical education. Something that I'm seeing through a lot of medical schools right now offer through global or urban medicine, rural medicine, and all sorts of these
Yeah, yeah,
paths that you can take. And oftentimes they're coming back. It's coming back here to Montana, and it's programs that are facilitated through schools on the East Coast, on the West Coast, and in the Midwest. So,
yeah,
um,
yeah. I think the thing about doing it in really rural areas, it's kind of scarier because you are a long ways away from help. And that was true in my time in Boulder. I mean, in some ways, my practice there, I was kind of lonely because I didn't have another physician to share things with. And I made contacts with the physicians in Helena, and I used them, as my referral base and that sort of thing. And I could always call, and run a patient by them or ask them questions. But you can feel pretty lonely when you're out in a rural area like that, and it's you're the only one that can respond when somebody needs help. And so it's a little bit scary. It gets you out of your comfort zone, that's for sure, and it forces you to really keep up and study hard. I had a professor when we graduated from medical school. He said, all this really means is that you've earned the right to you've earned the responsibility to study the rest of your life. And that's really true, because medicine changes so quickly that you really have to work hard to keep up. From the time you graduate, you're kind of always scrambling to stay current and to stay on top of things. And that's especially true if you're in a little rural area. You have to work hard to keep your skills up.
yes, of course. So eventually, you transitioned to working at St. Peter's Health in the emergency department. However, from our understanding thus far, you're a family practitioner, not an emergency medicine doctor.
Right.
So can you explain how family medicine doctors are able to transition to work in emergency departments? Do you need to complete another residency or any additional training? How does that work?
Yeah, I can tell you what my experience was. So I knew that I wanted to be a small town doctor. So I applied to a family practice residency when I graduated from medical school. And I went to Sioux City, Iowa. Sioux City at that time was around 85, 90,000 people, a meatpacking town, kind of a blue collar, tough town. There was a family practice residency in the town and no other residencies. This was a community-based family practice residency. And there were several of these, especially in the Midwest. There were several in Iowa and some of the adjoining agricultural states. But that turned out to be a real blessing, because we didn't have to compete with any other residents, for patients. And after you finished your internship year, then you got a medical license, and then you could work and get paid. And so we all moonlighted in the ERs. There were two big hospitals in Sioux City. Kind of think of Billings. It was very similar to Billings. There was a Catholic hospital and another hospital. And so we got to work, especially weekends and holidays. We got to work in the emergency department. We were the emergency physician, which again put you in an uncomfortable spot, because you'd finished your intern year, you knew a fair amount, but you weren't ready to be on your own yet. But it forced you to be on the spot, and it was great training. So we had all that emergency room experience. And in family practice, we had rotations. We did a lot of obstetrics. I delivered a lot of babies. We took care of the neonatal intensive care unit on our pediatric residency. So we got to work with very sick newborns. We did all the pediatrics. And Sioux City was a, excuse me, a referral area for all of kind of northwest Iowa, northeast Nebraska, and southwest Minnesota. So there was a lot of pathology, lots of really sick people, a lot of trauma went there. And so we got a really good experience. When I finished my practice in Boulder, the St. Peter's Hospital, when I first got to Montana, St. Peter's Hospital did not have full-time ER doctors. They had night coverage from 5 p.m. until 7 a.m. during the week, and they covered the weekends, and that was it. And there were ER residencies around the country, but not very many. And so they weren't turning out lots of emergency residents, and so people were doing it who had primary care experience. The old general practitioners who had a lot of experience were running ERs all around the country. And a lot of family practitioner residents were attracted to ER, and so they went from their family practice residency into ER practice. And the requirement at St. Peter's was that first of all, you'd be licensed in Montana, and secondly, that you have a residency in some primary care. So it could have been internal medicine, it could have been family practice, or it could have been pediatrics. Those were considered the primary care residencies. And I think family practice was an ideal training for the ER because you took care of everything from pregnant women to neonates to pediatrics to adults, excuse me, trauma, illness. We saw you got trained pretty much in everything during those 3 years of the family practice residency. And I found it was good training. And in contrast to some of my partners I worked with who went through ER residencies, they had far less experience in obstetrics and neonatology, especially than I did as a family practice resident. And I always felt pretty comfortable with pregnant women and with newborns. And I think some of the ER residency trained physicians were a little more uncomfortable with some of those things. And orthopedics, I got a ton of orthopedics. What I saw that my partners who went through the ER residencies, they did it in big centers and they had to compete for patients. You know, if somebody came into their ER with a broken bone, the orthopedic residents were the ones who took care of it. And so they were not nearly as comfortable reducing fractures or splitting fractures and that kind of thing. And I had pretty good training in orthopedics and a lot of experience in it. So I felt there were certain areas I felt a lot more comfortable in. I think family practice was good training for the ER.
Yeah, that sounds like you were great as far as the I guess non-critical patients who come in were mainly stabilized to where you could focus on the splinting and focus on delivery or focus on other aspects of care. Did you see any, I guess, deficits or any lack of experience in critical care and emergency medicine stabilization, the things that they're doing at those big centers in Seattle and Chicago and these bigger cities around the clock as far as trauma goes and things like that? Did you feel like that aspect of you was a little bit was lacking as compared to some of the emergency medicine specialized physicians, or not really?
No, not so much, because in my training, like I did rotations with neurosurgery when I was a resident in Sioux City. We all did advanced trauma, life support courses, ACLS, of course, we did all that. We worked in the ICUs. We worked with the cardiologists, nephrologists. We did rotations with all those people. So we all had some experience in critical care. My role in Boulder was very much like my role in the ER, really, was stabilization of the critically ill. But I felt comfortable intubating. I felt comfortable starting central lines. No, I think my training was pretty good, and I can't say that I felt like I was deficient anywhere. The deficiencies were in what was available. Like in Helena, working at St. Pete's, there was no neurosurgery. And so if you got somebody with a bad head injury, you had to stabilize them, which pretty much meant securing their airway and, trying to get their blood pressure adjusted. And then you had to get them out of there. There were lots of things like that we just didn't, Helena just wasn't big enough to be able to take care of everybody. And so we had to do a lot of stabilization and shipping. And that's kind of a skill. Shipping people is a bit of a skill too. I mean, you got to talk somebody into taking the patient. It's not like, you just get on the phone and tell them, hey, I'm sending this person up. You have to talk to the neurosurgeon and convince them that, yeah, this guy is somebody you ought to be taken care of. So you had to get good at that, at selling the patient and getting them out of there.
Of course.
But I felt comfortable taking care of everything I saw for the most part.
Oh, that's great. Yeah. And I guess we don't see, or at least as an EMT, I don't see that side of the speaking to the physician. We've just been doing transports to transport life flight crew to the VA or St. Peter's patient, then bring them to their airplane. But I'm sure there's quite a argument or quite a good amount of conversation on the phone as far as accepting that patient.
Yeah, and it's gotten harder and harder. When I first started in the ER, like if I had any head injury, any age, I could send them to the neurosurgeons in Great Falls and they took care of them. Now, if I have a pediatric patient, with a head injury, for instance, there's nobody in Montana, no neurosurgeon in Montana who wants to take care of a pediatric neurosurgical case. So you wind up shipping them to places like Harborview in Seattle or Denver or Salt Lake. I mean, it's gotten a lot harder because people are so much more specialized than they used to be when I started back in 91, that sometimes you really have to look long and hard to find somebody who will accept, a patient that before there were no questions asked. You just called a neurosurgeon. They said, yeah, send them up.
Right, and you alluded to something else in the generalist field now, that a lot of family medicine physicians were attracted to working in the ER. What is there any factor in particular that sways family medicine doctors to working in ERs? Are there any?
Well, I think the main attractant is the lifestyle. When I was in Boulder, I was the only doctor in town. I got up about 5:30 in the morning. I drove to Helena and made rounds on my hospitalized patients. And a lot of times I only had one patient in the hospital, but they were my patient, and I went and made rounds on them. Drove back to Boulder, started my office practice at 8:30, worked in seeing patients in the office until 5. At 5, I got in my car and I drove to Helena again and made evening rounds, because that was the practice at St. Pete's. If you hospitalized somebody, you saw them morning and evening, which was appropriate. But then I'd drive back to Boulder, and oftentimes I'd have somebody who had a sick kid or, wanted to be seen that evening, and I'd go home and have dinner with my family and then see a patient or two in the evening. And on the weekends, I would have office hours Saturday morning from 8 till noon, and then I'd be on call all the rest of the weekend. And I was on call all the time unless I left town, pretty much. So, I tried to take Wednesday afternoons off to go hiking or, just get out of town, get out in the woods. But people knew where I lived, and they just drive to my house and knock on the door, and my kids would answer the door, and they'd go, "Dad, there's a guy out here bleeding." So, it was very difficult to get away from. And I did that for 6 years in Boulder, and I was pretty exhausted at the end of the 6 years. And the public health service then, if you served 6 years in a health manpower shortage area, then after that, they would not let you serve in another health power shortage area. They considered it, hard duty, and they were going to transfer me to Denver to do a bureaucrat desk job. And so that's really why I left Boulder. I couldn't, there wasn't a big enough population to make a viable private practice, and I wasn't going to go to Denver. So I had to do something different. And I knew the people that worked in the ER. Dick Chess was the guy, the doctor that ran the ER back then. And I knew him from working, taking care of my patients at St. Pete's. And he actually called me and asked if I wanted to work in the ER. And I said, "Oh yeah, sign me up." So that's how that came about.
Yeah, who can ignore that great lifestyle?
Yeah, the lifestyle is what attracts people, and to some extent, a lot of ER doctors are adrenaline junkies too. They like that, not knowing what's coming in the door next, and they like that excitement of stabilizing somebody that's critically ill. And I liked it too. It was interesting, and all the best stories wind up in the ER. They really do. I mean, all the crazy stuff comes to the ER first, and I like that aspect of it. But the lifestyle, I think, to be honest, I think it's the lifestyle that when your shift is over, your shift was over. You weren't responsible for anybody else, and you could go home, and you worked long hours and you worked hard, but then you had a lot of time off and a lot of flexibility. So I love that aspect of it.
To the Carroll PMC pre-med, the future medical generalist, looking between family medicine and emergency medicine, looking back, do you prefer one over the other?
Well, the nice thing about family practice was that you really got to know your patients and you got to follow them over time. And it was cool. It was very rewarding to deliver a woman and then take care of her baby and take care of that kid as it grew up. And that was really very cool. And to see people through those whole phases of their family life cycle. So that was nice. In the ER in a small town like Helena, you get a little bit of that because you see the same people over and over, and you get to know a lot of people. Not as in depth as you do in family practice, but the lifestyle was just so much better in the ER, and both of them were great jobs. But when I started in the ER, I did kind of miss that aspect of following people through their life, and I think that's the big attractant of family practice.
Yeah, and I think choosing specialties like that, again, like we've spoken about on the podcast on the video interview series, a couple of providers have said it comes down to the 3rd and 4th year of medical school and the rotations and the experience
Yeah.
you have from them. I think that's definitely going to be the differentiating factor between a lot of Carroll pre-meds like myself who are swayed between family medicine and emergency medicine, because there's a lot of crossover.
But you may find when you're in medical school that you love oncology, or that you fall in love with obstetrics, or you fall in love with cardiology. I mean, people, when we started as freshman medical students, people had an idea what they wanted to be, but I'll bet more than half of them wound up doing something that they hadn't considered when they first entered medical school. You just really don't know. There were people that thought, oh yeah, I want to do OB, and then they did their OB rotation and they found out, I don't really like this. I hate it, in fact, and so they did something else. So it's hard to tell. I mean, until you're there and you get the real experience of it, you don't know exactly what's going to grab you.
Well said. So speaking to a lot of family medicine, internal medicine qualms that we see in the nation, is lack of primary care access.
Yeah.
So what do you believe personally contributes to the lack of primary care across the nation, and how has this exactly impacted emergency departments?
Well, I think there are a couple of factors. One is the lifestyle, that family practice is very demanding, eats up a lot of time. And two, to be quite honest, is that it doesn't pay as well as some of the other specialties. So you put in a lot of time, especially if you don't do a lot of procedures. In America, we have always paid people more if they did procedures than we paid people who fought hard about their patients. I mean, taking care of a sick diabetic who has high blood pressure and heart disease and thyroid trouble is way more demanding than operating for appendicitis. And yet the surgeon gets paid a lot more for taking out an appendix, which I'm not saying that's a trivial thing, but it's a procedure. You could teach a lot of people how to take out an appendix, but taking care of somebody who has multiple medical problems and is quite sick, that's much harder to do. I mean, in terms of what you have to know and the time you have to put in thinking about. We've always underpaid that. So family practice is underpaid, and I think that influences a lot of people's decisions. And then locale, I think, people don't want to be stuck out in really rural areas where they're kind of all on their own and they're a long ways away from help, and they're underpaid and they're overworked. And so I think that's the real challenge of primary care and family practice. ER, on the other hand, the lifestyle is better, tends to be paid better because you do a lot of procedures in the ER. And it's just more attractive in a number of ways.
Yeah, and there's a complication out there that a lot of people hear, and I guess it really depends on just the status of the healthcare system as in the nation. But a lot of times people hear that it's in the news headlines, patients abusing emergency departments because they use the ER for a primary care physician. Can you elaborate on what the disadvantages are of doing that?
Yeah, and I think that as primary care shrank, numbers of primary care practitioners shrank, people went to the ER because it's the only place they could go. And so we did a lot of primary care in the ER. I didn't mind it personally because that's, I was trained to do that in my family practice residency. Um, it made you busier and busier, which was the downside of it. But it was still people that needed help, and a lot of them didn't have any alternatives of where I was going. And that it wasn't just the lack of primary care, and to some extent, it was the lack of insurance. If there had been a universal health care insurance, I think a lot of those people would have had primary care providers they could go to. But the thing about the ER was we had to see them whether they could pay or not. When I first started in the ER, our reimbursement rate was in the 70% range. In other words, we got paid for about 70% of everything we billed, which was pretty good. We didn't realize how good we had it. That slipped every year. And when I left in 2018, we were down in the like 40% range. So you got paid for about 40% of what you did because people didn't have health care. They didn't have insurance. But if somebody came in by ambulance, morally you had to take care of them, and legally you had to take care of them. And you had to do everything you could for them, just as though, they had Blue Cross Blue Shield premium insurance. So that I think is part of it too, and that's a part of why the ERs are sort of glutted with primary care patients. But I didn't mind it. I mean, you got into it to help people, to take care of sick people, and for the most part they were. Now, are there people who abuse it, who are just seeking drugs and stuff like that? Sure. But they really are a fairly small percentage. And, you learn ways to deal with that over the course of time. And it's kind of a nuisance, but it's not a horrible thing.
Right. And speaking to healthcare insurance, and I'm sure you've had great experience with that as far as insurance goes, because I guess in the emergency department that's not really a factor because you're not too as large a factor because you're considering every patient who walks in the door as well. We're treating this patient as far as the ER works, but
Yeah.
family medicine wise, likely you fought for coverage for a lot of those a lot of patients, coverage for people to get the medical care that they deserve. And I think this brings us to this is a great foundation for the second to last question I'd like to elaborate on, which is about the national health care. In America, we spend more on healthcare per capita per person than any other country in the world, and logically we suppose that we would have the healthiest people and the best healthcare because of this. But the results of studies by medical schools, by institutions all across the nation beg to say otherwise.
Yeah.
My question to you is why is that? And how do we begin to fix this?
I think in large part it's because we've devalued primary care. And primary care is where you get your preventative care, where you get your maintenance care, and that's really what builds healthy populations. If you look at the countries that do much better than us for less money, take the Scandinavian countries. They have universal health care, but they really have amazing primary care, and preventative care, is all paid for by the national system. All their maintenance care is paid for by the healthcare system. We spend all of our money on people after they are critically ill, and we're very, very good at that. Our technology is the best in the world, but we're spending it all on people who are already critically ill. If we just had some sort of universal healthcare insurance, then people could go to their primary caregiver. They could get the health maintenance stuff that they need, the preventative stuff, the screening stuff. They could get education on healthy diet, healthy lifestyle. There'd be support to help them get off of substance abuse, to help them quit smoking. We just haven't done a very good job of that. And when you're building at a population level, you're trying to improve the health of a population, you really have to put all that money forward into the preventative and the health maintenance stuff. And we simply haven't done that in America. And I think it's shameful, actually, that we're as rich as we are, and we have, all of these chronic disease problems that could have been prevented if people just had a better healthcare system to help them.
Well said. So, as we wrap things up, and as the Carroll pre-medical student is listening to this and struggling on their journey towards medicine, what final words of wisdom do you have for them?
I don't know if I have any words of wisdom. I think if you are attracted to medicine because you saw a cardiologist driving a Maserati, I think you are misguided. I think you should go into this because you genuinely feel like you want to help people, and another part of it is you genuinely love biology. I mean, a lot of the satisfying part of medicine is the ferreting out what's wrong and then figuring out how to treat it. That's intellectually very satisfying. And then knowing that you're doing good for people is very satisfying. I had a professor tell me once, if you really want to save a lot of lives, you should go into refrigeration or into civil engineering and design sewer systems, because that's really where you save lots of lives. On the other hand, in medicine, what you do is relieve a lot of suffering. Death comes to us all, and you don't necessarily save everybody that you take care of, but you relieve a lot of suffering. So go into it because you want to take care of people, you want to help people, you want to relieve suffering. You will have a comfortable life. You should not get rich doing this, but you will have a comfortable life. You'll make a comfortable living, and you'll be very much rewarded. It's a daunting experience. It's kind of scary when you think about it. You're responsible for people's lives, and malpractice is always looming out there, and there are a lot of things that would discourage you from going into medicine. I always looked at it as, well, somebody's got to do it. I'm willing to work hard enough to be able to do it, and it's been worth it. It's been a good career. It's been very rewarding on every level I can think of. So, you got to just power through the downside and enjoy the good parts.
And with that, we end another episode of Carroll PMC's video interview series and wrap up another story for you guys. A quite multifarious story by virtue of the diverse range of experiences that Dr. Kuntzweiler has had. However, a discussion that ended and touched on a topic that is a hot topic in medicine, that of preventative care. Instead of jumping to the prescriptions, looking at the factors in one's life such as diet changes and exercise regimens, interventions that can be placed to address certain factors in one's lifestyle that will prevent the diabetes, that will prevent the chronic lower back pain, that will prevent different things that are going to, one, ail the patient for many years to come, and two, cost a large sums of money in prescriptions, in surgeries, etc. It's something that I believe Dr. Kuntzweiler has had great experiences in, and that he's touched on greatly throughout the entire interview by virtue of his multiple years practicing as a primary care physician. And it's something that the AAMC and the AMA has posited as the future of medicine, as how we will begin to approach patients as the next generation of physicians. And it doesn't take a brain surgeon to figure out that a penny's worth of preventative care is worth as many dollars as that of sick care. Thank you for taking the time to listen and or watch me. Hopefully this helped you guys gain some motivation or insight into what it takes to become a successful pre-medical student. As always, if you have any questions, feel free to reach out to your Carroll PMC officers, schedule an office hour slot with myself on Moodle, or consult with Carroll faculty of your choosing. Have a great day, and I'll see you next time.